practicing urologist in Springfield, Missouri. I've been there for about 28 years now, and developed an interest in healthcare IT when, as a slightly younger physician, could not find an EHR that I could use. Back in the early 90s, EHRs at that time were based on a template system, and urology is a very small specialty, and didn't find very many EHRs that cared to build templates for specialists, and especially didn't care to make it easy for specialists to build templates for themselves. So I got interested in healthcare IT. I actually built an electronic health record for urologists in the early 2000s, and hats off to the fellow who presented earlier that's building the EMR in the specialty practice. Good for you. That's the way you make real progress. I was inspired by that. I want to say thank you for the invitation to the meeting. This is a great meeting, and a sense of community exists here that I don't see anywhere else. So I appreciate the invitation to the HL and HL7 FHIR folks. So Juxlee is a nonsensical name. I wish I had a great story for you, but the .com was available, and we kind of liked it, so we went with it. Truth. I'm going to show one of our apps. We're a company, this is not the company, this is not the EHR company. I was a little confusing there. This is my second startup, and Juxlee builds FHIR apps that plug into EHRs. It does maintain my passion for making EHRs more usable at the point of care. And I care particularly in my heart for doctors, nurses, patient managers, care managers, anyone, medical assistants, anyone that's on the front line in a time-sensitive relationship with a patient, meaning they're face-to-face with the patient and they have some work they have to get done. I'm going to talk about Vault today. Vault is one of our apps that's available in a couple of the major EHR app stores, and we are working with a variety of EHRs to integrate this app. It's currently integrated in Cerner and Epic, and we're working our way down the list. I want to tell you a little bit about Vault. We are really, as you can get from my introduction, I'm really interested in user-centered design, application design. When I started reading about it, there were no such thing as medical informaticists because I'm really that old. But the idea that we can really design apps for users is really close to my heart. So we do intend to deploy this app in multiple different EHRs thanks to the FHIR technology that's been developed. And over the last 3 years, my development shop, a relatively small shop in Springfield, Missouri in the Midwest, has really become pretty proficient at building these apps, both for ourselves and on a contract basis. We build custom apps. Let me talk for a minute about value-based care, because Vault is based around the proposition that we're going to move from fee-for-service care to value-based care, and you've all heard the buzzwords. The idea here is to be able to quantify the severity of illness of a patient so that you can price the risk of taking care of that patient. And that's important if you're a health plan or a hospital system or a physician, that you understand, number one, how sick your patients are in a value-based world, and what kind of resources and money it's going to take care of them. And so there's a definite business use case, but there's also a good old-fashioned medical use case, and that is the problem list that all physicians and nurses learn about in medical and nursing school has to do with a list of the patient's problems. And value-based care is all about what's called HCC codes, which is a subset of those problems that have chronic disease implications. So let me say that a little more clearly. If you have a bunch of chronically ill patients, you need to use HCC codes to quantify exactly how sick they are, because it has downstream ramifications on resources, money, reimbursement, etc. in that new value-based world. So accurate risk stratification, that second point, is extremely important. Whether you're a health plan or a hospital system, that you stratify the risk of the population of patients that you are taking care of in a value-based world. So analytics, metrics are really important for following that risk and quantitating it. So Juxly Vault is the third app that we built. It has a very focused use case, and I'll go through that in a second. It is embedded in the EHR workflow, which many of you realize and know at this point. If deployed that way, it's typically a deal breaker, because it's been mentioned several times this morning how busy physicians are. And, honestly, we are busy. And so signing on to a third-party portal or going on and using another username and password, it's really a non-starter in a busy clinic location. If a physician moves to different EHR situations, and that's not uncommon to use one EHR in the outpatient setting in your office and a different EHR at your hospital, potentially a third different EHR at your long-term care facility or your ambulatory surgery center, this is really not an unusual situation. So one app, same user experience wherever you go. One thing we've done at Juxlee is we've been really interested in going after gaps in care with patients. It's a slightly different use case than risk coding, which is my fourth button, but let me talk about gaps in care. Gaps in care is basically taking good care of people, getting them in for their colonoscopies, their mammograms, their flu shots, the things they need on a regular basis, keeping track of those things and taking good care of your population. Risk coding is what I was referring to earlier, the HCC quantified coding or quantitative coding of these patients. So I'm going to show you a live demonstration of Juxly Vault, and I have with me today Mark Gidman, who is our Chief Technical Officer, who fortunately builds all of the stuff he actually doesn't build all the stuff I dream up. He just builds a lot of it. He tells me no a fair amount of the time. So Mark, we're going to show
Can we have the...
Can we switch to the browser? We're going to open Juxly Vault and imagine that it's wrapped in the wrapper of an EHR. You still have the browser?
Yep, getting there.
Could we put the browser on the big screen? That'd be great. There we go.
Still loading.
The app is actually still loading, but let me tell you what's going on at this point. Inside the EHR through OAuth 2.0 mechanism, the patient's chart is opened in the EHR. The doctor clicks on whichever nav bar he normally uses inside the EHR. It is in his normal workflow, and he opens this app. And so two things have happened here. All of the patient's problem list has moved from the EHR into the app. So the problem list is essentially a set of ICD-10 codes that represent all of the illnesses that the patient has. This is a very simple color coding scheme. I'm a urologist and I need things simple, not a heart surgeon, not a brain surgeon. So we've got gray codes, which are ICD-10 codes, which are not mapped to the HCC subset. So gray codes do not represent chronic disease. There are other things. There are acute sinusitis. There are fractured forearm. There are things that don't have chronic implications in those patients. They can be dealt with acutely. Yellow codes or orange codes are HCC mapped codes that have not been completely documented per CMS criteria. Those are called MEET, Monitoring, Evaluation, Assessment, and Treatment. It's a documentation requirement of CMS. Green codes are HCC codes that are completely mapped. In the top left of the app, we have a patient indicator which totals up the green codes and calculates what's called a RAF score. And a RAF score is simply a risk adjustment factor that's calculated from all of the HCC codes and a small demographic component. So let me just, to simplify that, if you add the green codes together, that's the HCC line, and this patient has a RAF score of 0.56. Let me give you a reference. 1.0 is the arbitrary normal amount of illness in a patient or a population, 1.0. So if you're below 1.0, you're healthier than normal. If you're above 1.0, you're sicker than normal. So that's the reference point. So I'm going to click on a gray code over here, and what will happen, this is an opportunity for a physician or a provider or a nurse practitioner to turn a gray code, which is non-HCC and is not relevant in a RAF score, to turn it into an HCC code. So all of these returns are HCC codes, and they're presented to the physician with the sense that, hey doctor, look at these codes and see if you can ethically and accurately choose one of these instead of the green code. So when we choose one, we're actually going to choose an HCC code, and it's going to open a MEET documentation screen. And Mark is actually going to do a quick MEET documentation of this patient while he's face-to-face. So in a period of 5 or 6 seconds, he'll actually move down the MEET criteria And as he selects these meet criteria, he's actually building the HCC documentation, the textual documentation that's required by CMS to justify the code. If you'll notice that orange code, we went from gray to orange and now to green because we're fully meet documented. So we've added a code that's more accurate to quantify the patient's chronic illness. When we click Save, this code actually appears in the list. If you'll notice on our estimate in the upper left, this patient's calculated RAF went from 0.5 to 1.03. So in real time, there's direct feedback, and that RAF score is a loose approximation of how sick the patient is, just to put it simply. Two things happened. That code went back into the EHR through the FHIR API, so the EHR problem list does remain the single source of truth. That's very important. And the second thing is that meet documentation that I showed you that was being built, it went back into the EHR, linked to the encounter, or put inside of the note, depending on the EHR, and we're at a little bit of mercy of the EHR as to where that documentation goes, but it is in the EHR. Those two things are very important because occasionally CMS will actually audit a hospital system or a provider group. It's called a RAC audit. And when they do a RAC, it's not. It's called a RADV audit. I misspoke. It's called a RADV audit. When a RADV audit is done, you have to justify all of the codes that you've submitted to CMS, and that includes the meet documentation that we talked about. There's another change in our app in the last few months, and it's called dashboard functionality. So I want to briefly tell you what that is. The functionality I've talked to up to this point has been within the EHR. It's been between the EHR's FHIR API and our app. We have the opportunity to build third-party relationships with outside companies. Now let me give you examples. It could be a health plan. It could be a hospital system. Any sort of outside the EHR kind of interest that's interested in producing intelligence, analytics, suggestions, and inserting those into the doctor's workflow, we have the capability to do that. So Dashboard is a way that an outside company could suggest an HCC diagnosis to our doctor. Now let me make that clear. That's a diagnosis that the EHR doesn't know about for whatever reason. So I practice in Springfield, Missouri. If one of my patients goes to Miami, Florida and has an MI and a pulmonary embolus and they're in the hospital for 3 weeks, the insurance company may know all of that. My EHR doesn't know that. And so this intelligence can be put in front of the physician with the justification or the reasoning why this third party thinks the patient has these problems. The doctor can then accept that and click search. And when he clicks search, he goes to the screen I just showed you where he can pick an HCC and meet document it. Or he can reject it. He can say, you know what, this patient does not have high blood pressure despite what you think. He can accept it or reject it. And then at the end of the day, we can actually send a message. We can send a message back to the third party from the entity about what the doctor did. He accepted it, he rejected it. If he accepted it, look for it downstream on a claim, for instance, if you're an insurance company. So just to clarify, we have the capability of taking outside intelligence with appropriate BAAs and contractual relationships, of course, and insert data into the physician's workflow that he might not otherwise be able to ascertain from the EHR. And on the right side of this screen is a simple set of analytics. Some third-party companies are interested in perhaps changing the comp plan of physicians and healthcare providers. In a value-based world, remember, when we're no longer paid on productivity and what we do, there will be some innovative new ways to pay frontline providers. And one of those might be, hey, doctor, of all the care gaps we've sent you, you've addressed 77% of them. But we have a comp plan tied to that, and we'd like you to get up to 80% or buckle down and address your care gap. So it's just simple analytics to get providers to use apps and complete their work. So that can apply to care gaps or HCC risk scoring. Let me talk about care gaps for a moment because that's a functionality that we can also accomplish, and that's an outside party injecting the colonoscopy, mammogram, flu shot data into the EHR, again, right in the doctor's workflow, reminding him that he needs to get those things done. It's a separate module. We've also built this dashboard in modules, and by that I mean We can have, if it's relevant, if the patient sitting in front of the doctor is a Blue Cross patient, these can be Blue Cross suggested HCC diagnoses, context specific to that patient. If the patient in room 2 is with Humana, and we have a contract with Humana, we can also insert Humana HCC diagnoses or Humana care gaps. So we purposely built this in a modular way so that we could accomplish or accommodate the needs of multiple outside entities that are interested in access to the EHR. So I'm getting a big red stop sign. Once again, thank you to HL7 and FHIR for the invitation, and I hope to visit with many of you later. Thank you for your time.